Inshallah, it's my pleasure to be the moderator of this discussion today, and I hope it will be useful for all of us regarding thymic surgery, inshallah. May I ask Dr. Al-Hamoumi to start his presentation, please?
إن شاء الله. بسم الله. بسم الله الرحمن الرحيم، وصلى الله على نبيه الأمين. أخوكم الدكتور محمد ماسين الحمومي، طبيب جراحة صدر بالمستشفى العسكري محمد الخامس، التابع للمركز الاستشفائي محمد الخامس وكلية الطب والصيدلة بالرباط. نرحب بكم في بلدكم المغرب من طنجة إلى القويرة، ونقدم الشكر الموصول للإخوان الذين قاموا بتأسيس هذه المجموعة قصد التواصل العلمي. الشكر الجزيل، وأيضا الشكر الموصول للأخ دكتور عامر إبراهيم على المجهودات التي يقوم بها وجنود الخفاء الذين يساعدونه. شكرا جزيلا. Here we will speak about the myasthenia gravis surgical indications and techniques. Myasthenia gravis is one of the best treatable autoimmune disease, and the long-term medical treatment is associated with a lot of related side effects. So when surgery is indicated, maximal thymectomy is a non-pharmacological disease-modifying therapy with a class 1 evidence benefit, but we have some questions that remain unaddressed. Minimally invasive techniques replaced open surgery with available evidence benefit. So surgeons should make a selection of patients and control the myasthenia gravis in the preoperative stage. The investigation of myasthenia gravis related biomarkers has an impact on the specific immune response. Surgical reminder, we know that the thymus gland is located in the anterior mediastinum behind the sternal manubrium, and it gets vessels from the neighboring structures. In this view, we can see that in the majority of cases, thymus is intrathoracic gland, but we have some cervical extension. So surgeons should know these ectopic locations to remove during the surgery. We have to emphasize that the phrenic nerves are gold structures to preserve during surgery. A word about physiopathology. In normal neuromuscular junction, we know the role of the released acetylcholine, but in myasthenia gravis neuromuscular junctions, there are some autoimmune antibodies, especially anti-acetylcholine receptors, anti-muscle specific kinase, and anti-low density lipoprotein related protein 4 that block this junction and give myasthenia gravis symptoms. History of thymectomy began before 1941, but in this time, Alfred Blalock was the first to present his clinical trial with a serial of median sternotomy that show real benefits of thymectomy in myasthenia gravis people. In 1980, we will understand physiopathology partially of myasthenia gravis and the use of plasmapheresis and immunoglobulins. In 1997, the American surgeon Alfred Jarewski will say, thymectomy literature is replete with confusing data, variously defined measurements, and unsupported conclusions. So he concludes and recommends that we need a uniform classification of severity symptoms, a clearly predefined measure of success, and how to compare the benefits of thymectomy technique. He will describe the combined transcervical and transsternal thymectomy as a maximal thymectomy technique, and he believes that the more aggressive is the resection, the higher is the remission rate. We will wait until 2016 to have a long-awaited results about a randomized multi-center trial published in the New England Journal of Medicine with about more than 6,000 patients. And we conclude of a positive impact of thymectomy. But this trial has some limitations about the base of patient selection, the use of a very complex method of evaluating the outcome, and the absence of data about the achievement of complete remission. The medication protocol was used only with prednisone without newer immunosuppressive agent, so that no possibility of comparing the results of this trial with previous or future studies. After more than a century, we can conclude that questions are still present. Who and which of patients will choose to surgery, when to consider thymectomy, what procedure to use, and how to evaluate the benefit. Diagnosis steps in myasthenia gravis are, first of all, the increased complaints with activity and spontaneous remissions in anamnesis. We have the improvements in muscle strength after use of anti-acetylcholinesterase. Repetitive nerve stimulation tests show reduction in potential response and single fiber electromyography. We can use anti-acetylcholine receptor antibody detection, and in the radiological thymic finding, it is even atrophic thymus, a normal thymus, or hyperplastic one, or we can have also a thymoma. So that some clinical classifications have been developed, like the Osserman classification system that include 5 stages about the only ocular involvement in stage 1, stage 2, generalized muscle involvement, stage 2B, bulbar manifestations, and 3, the rapid generalized bulbar disease with respiratory muscles, and stage 4, the class 1 or 2 within 3 years. Another classification is this of the Myasthenia Gravis Foundation of America. According to the involved muscles, it is a generalized myasthenia gravis or ocular. According to the onset age, before 50 years old or after 50 years old, according to the present antibodies, anti-acetylcholine, anti-muscle specific kinase, and double seronegative. And last, according to the presence or not of a thymoma. So what are the treatment options in myasthenia gravis? There are 4 options. The first one is medical treatment. Basically, it is anticholinesterase agent, pyridostigmine. Secondary, we can use immunosuppressive treatment, corticosteroid first, azathioprine, methotrexate, tacrolimus, and cyclosporine. And in some situations, when we require a rapid recovery, we can use plasma exchange and intravenous immunoglobulin. And before the thymectomy operation, we can use this procedure. The fourth option is thymectomy. And we will see in 2017 that the American Association of Neurology concluded that thymectomy is an effective indication in some group of people. So this is the most important diapositive in these presentations about the indications of thymectomy. The first one is thymomatous myasthenia gravis, about 10% of cases. In all thymoma cases, when tumor is resectable, the patient is operable, regardless of the status of myasthenia gravis, is it generalized, bulbar, or ocular, thymectomy should be performed with a complete resection of thymoma, and this is made after a multidisciplinary decision. We have to say that in people with thymomatous myasthenia gravis, remission and recovery rates are worse than people without thymoma. Dr. Smati will speak about this more. Thank him. The second indication is about non-thymomatous myasthenia gravis with positive anti-acetylcholine receptor antibodies, about 60 to 80% of people. According to the last update in 2020, the International Consensus Guidance for Management of Myasthenia Gravis gave 4 recommendations. The first one is in non-thymomatous generalized myasthenia gravis people with positive antibodies, age from 80 to 50 years, thymectomy should be strongly considered early to improve the clinical outcomes and to minimize the immunotherapy use with a level B of scientific proof. When your patient failed to respond to immunotherapy or have some intolerable side effects, thymectomy can be proposed. The second advice or recommendation is that thymectomy for myasthenia gravis is reserved for people in stable condition. The third recommendation is the use of less invasive thymectomy approaches. And the fourth one, we will see it later. The second indication about age and the gender of your myasthenia gravis patient, an age limit. There is no age limit for thymectomy, and it is not demonstrated anywhere. But we have the reputation of 80 to 50 years old people that respond well to thymectomy, especially younger women more than older men. Older people more than 70 years old will respond less to thymectomy because of high thymic involution incidence and risks of thymectomy. We have another indication, formal indication, is the frequency of infraclinical thymoma in autopsic serials that made thymectomy mandatory or a frequent indication in older people. So in this study, we have a clear improvement of people aged more than 70 years old. We have the improvement in postoperative thymectomy. Another type of myasthenia gravis is juvenile myasthenia gravis. In younger people, thymectomy was frequently indicated in severe medically refractory juvenile myasthenia gravis. In a study about 500 patients thymectomy from 1997 to 2020, we describe about 77% improvement in clinical, 77% improvement in clinical status with reduced requirement for medical therapy. Complete remission was seen in 40% of cases, but we have to say that more than 30% of young people will develop some complications. It is a high group risk. Thoracoscopy, when used, gave more improved outcomes with fewer complications and better cosmetic outcomes. We find some classical positive prognostic factors in the literature: early intervention, just after puberty, positive antibodies, and severe disease, or the presence of hyperplastic thymic tissue in the computed tomography or MRI. In pregnancy is known to cause an increase in myasthenia exacerbation. And this group of people is a high-risk group. So young people, young women with pregnancy shouldn't benefit from thymectomy until the post-pregnancy stage. Here we are in a particular group of partial myasthenia. It is ocular myasthenia, about 50% of cases. The role of thymectomy in ocular myasthenia gravis is controversial. We have to say that in 50% of cases, people will generalize the myasthenia gravis during the first years of progression, especially the female sex and especially with people with positive antibodies. So that some clinics do not recommend thymectomy for patients with ocular myasthenia gravis, but in other studies, it is really recommended with less invasive procedures indication, like video-assisted thoracoscopic surgery. If your patient is unresponsive to drug treatment with a high risk of progression to generalized myasthenia gravis and positive anti-acetylcholine receptor antibodies, propose thymectomy. But there is no significant indications for thymectomy for people with ocular type and double seronegative myasthenia gravis. In this study, thymectomy in ocular myasthenia gravis will result in better clinical outcomes before generalization. It isn't the same thing after generalization. Muscle-specific kinase antibody positive myasthenia gravis people in 1 to 10% of cases, these antibodies are rarely found and associated with a severe myasthenia gravis, touch more women than men, and it concerns more than 40% of people with negative anti-acetylcholine receptor. In a study by Guptil and Collab, about 40 thymectomies and 70 patients who were not operated, all with muscle-specific kinase positive myasthenia gravis, he speaks about a possible benefit of thymectomy. But in the other clinics, many clinics, in fact, do not describe a benefit of thymectomy in this group of people. So that we should emphasize of the role of the medical treatment to optimize the control of the disease, what we call medical thymectomy. Another group of myasthenia gravis people is double seronegative myasthenia gravis. The role of thymectomy in this group is not yet fully understood. So in this situation, we can look for biomarkers like cortactin, that is a protein acting downstream from the agrin LRP4 and muscle-specific kinase, that is called like an antigen detector in double seronegative myasthenia gravis people. However, most clinics recommend thymectomy in these cases. In children with double seronegative myasthenia gravis, congenital myasthenia syndrome should be assessed before thymectomy. The last indication is rethymectomy in post-thymectomy myasthenia gravis. In this study, we can understand that after a large thymoma resection with a partial resection thymus, partial thymectomy, some people will describe a post-thymectomy myasthenia gravis. And in this case, we indicate to do rethymectomy to remove all the remaining tissue. There is another explanation of the syndrome of post-thymectomy myasthenia gravis is about the long-lasting peripheral circulating autoantibodies. So overlook of the indications, all the indications inside the O is okay for surgery for thymectomy, thymoma, young female, old people, ocular myasthenia gravis, positive anti-acetylcholine people, refractory myasthenia gravis, okay for thymectomy. But we have to discuss in the case of positive muscle-specific kinase or in double seronegative myasthenia gravis people, and even in juvenile myasthenia gravis with a multidisciplinary management. Here we are in the surgical methods. The target of the surgeon is the easy access to the anterior mediastinum and complete removal of the thymus and extracapsular mediastinal and cervical thymic tissue. Before surgery, we should prepare our patient. Thymectomy scheduled patient must be in optimal medical condition. We can indicate forced vital capacity to estimate the post-operative prognosis, and we can have a use of rapid immunotherapy with plasmapheresis or intravenous immunoglobulin before thymectomy to improve the respiratory or bulbar signs. So how to do surgery? Is it by the transcervical approach, the basic one, the extended with manibrotomy, the video-assisted extension? Is it via transsternal and transcervical thymectomy? Is it by the transsternal thymectomy standard or extended, or by the infrasternal thymectomy, transcervical and subxiphoid combined approach, video-assisted or robotic-assisted subxiphoid approach, or via the infrasternal mediastinoscopy? And we can also use the video-assisted thymectomy, one side, double side, cervical dissection, unilateral assisted or bilateral assisted robot. In the history, the use of each approach was a real evolution. We began by the transcervical, after it is the transsternal thymectomy, and after nowadays it is the subxiphoid way using the engineering, video and robotic surgery. Transcervical thymectomy allow intracapsular dissection, removing only the central cervicomediastinal portion with a remission rate about 24%. It allow extracapsular dissection with removal of all the visible mediastinal fat. Less invasive, slight aesthetic cost, but it doesn't allow a good resection, a complete resection of the mediastinal pleura layers. 27% of people will be reoperated by sternotomy because of the worsening of persistence of the myasthenia, with about 10 to 60 grams of persistent thymic tissue. This technique should be abandoned, but people are still defending using unipartal transcervical thymectomy, and this describe a good results. We will see this later. Complications are risk of injury of the nerves. We see here we have a limited view, a small skin incision, but a partial removal of the thymus. Transsternal thymectomy, it's the historical reference method, 13 or 44 remission rate of myasthenia gravis patient. It gives high quality exposure, extensive resection of the thymus and the mediastinal thymic fat, resection of the mediastinal pleural sheets, and a resection of the fat of the aortopulmonary window and the thyroid inferior pole. But we have some aesthetic sequelae, more in young women, limited resection of the cervical fatty tissue. A future sternotomy will be more difficult. We have the risk of injury of internal mammary vessels that can be used in a future cardiac bypass surgery, parietal morbidity, particularly with patients avec corticosteroid long use, and alterated respiratory function and use of frequent chest tube insertion. The transcervical and subxiphoid approach, it is a safe technique to avoid a sternotomy by a double skin incision in the neck and in the infrasternal area to perform what we call maximal thymectomy. And we need here a sternal fracture. It is a time saver technique, but it is rarely used nowadays. Vas thymectomy, minimally invasive techniques that developed in the last 20 years through an intercostal approach. Each side is possible, the left one and the left one and the right one. In our teamwork, we prefer the left one because of the easy access to all the thymus gland and with possible dissection of cervical part. People defending the right side speak about the easy access to the right cardiophrenic angle. People defending the left side think that the dissection is easier to the aortopulmonary window. Bilateral VATS thymectomy is possible, but we prefer single port thoracoscopy, especially in thymomatous people that can give less pain with good results. In this study about each side to choose, we see that the left side give lower operating times and give a superior medium-term symptomatic outcomes. Here we are in a personal experience in our department. So this is the superior vena cava. This is the innominate vein. After a thymectomy, the surgeon have to remove all the remaining fat tissue in the thymic cavity because it can contain thymic ectopic tissue. So the removal is important. The surgeon should make a complete check of the cavity to remove all the fat tissue. So I will go fast. Finally, we check all the area to remove all the remaining fat tissue. Video-assisted infrasternal thymectomy. This technique is possible via a uniport approach, possible insufflation of CO2 gas. It gives complete remission about 37% of cases with a good bilateral exposure of the mediastinum. The disadvantages, it doesn't give a possible removal of the cervical fatty tissue. Robotic assisted thymectomy, it is the exploding technique. Robotic or surgery has benefit from the development of engineering, and engineering really give a positive impact to surgery. Using the robo-assisted thymectomy, using the Da Vinci system, 3 or 4 articulated arms connected to a control console with a training operator and operating room team. Everybody should be trained to robo. In the case of thymectomy, robotic surgery is a cheap intervention because of no use of staplers. So we can encourage people to do. In this view, we see a robotic left approach with 3 ports or 4 ports. This is an accessory one with a good access to the left side, to the aortopulmonary window, and even the cervical area. The use of single port thymectomy by subxiphoid approach in robo is possible with good exposure, but sutures are more difficult by robo in this situation. Some people propose the bilateral side robo. It gives a better exposure, but it is a very time-consuming step. About 13 to 51% of remission. Common advantages of video thoracoscopy and robotic is first, less parietal morbidity, less post-operative convalescence, less severe cosmetic sequelae. So, plus we have a very good view of the anterior mediastinum. The mediastinal fat and the thymic gland is completely removed. Less frequency of post-operative myasthenic attacks. There are real advantages, and we hope to do one day. The robo has the following additional advantage: 3-dimensional vision, 360 articulated arms with 7 degrees of freedom, more than the human wrist, comfort for the surgeon. He is seated in front of the control console, feasible dissection of the cervical fat, and easy access and dissection of the aortopulmonary window. We here see in this view, in the left image, how the removal of thymic tissue was complete. Really, with the supra-aortic vessels, it is completely removed, and it is a very good approach. Sequela are really acceptable and not very bad. Some disadvantages of video-assisted thoracoscopic surgery is a two-dimensional view, not like robo. Difficult dissection of the right perithymic cervical fat. Some disadvantages of surgical robo. It is really important. The cost of the device, not every country can have robo, so it is really costly. But if we compare the cost of hospitalization, all the global cost, robo is cheaper, is best than sternotomy. And the second disadvantages is the absence of force feedback. It is important to say that in robo, we have an elimination of the force feedback to the surgeon, and the surgeon cannot measure the power to give to the surgical instruments, so he can increase the power to the tissue, and it is in favor of some accident during the training stage. The third disadvantage is the morphotype of the patient. Some people obese or with a long use of corticosteroid may be difficult in robo. And a very important thing to say about robo, it is not currently a motivating learning environment for medical students and resident doctors. So we have to find a solution. In this table, in French language, excuse me, Amir, in French language, in Encyclopédie médico-chirurgicale, a comparison of different techniques, transcervical approach is not recommended anymore. Transsternal approach is used when we have a thymoma more than 3 centimeters. And thoracoscopy and robotic assisted thoracoscopy is the most indicated techniques. What are the adverse effects of thymectomy? After this surgery, we can have many problems, particularly the high risk of impaired respiratory function with the delay in intensive care unit. The mortality rate is less than 1%, even in cases with severe myasthenia gravis symptoms. Some complications like myasthenic crisis, infections of the wound, and recurrent or phrenic nerve injury are less frequent. Other complications are depending on the surgical approach. In conclusion, thymectomy results in clinical improvement in people with positive anti-acetylcholine receptors antibodies. Minimally invasive thymectomy is the most valid treatment option for patients with both non-thymomatous and thymomatous myasthenia gravis. But in some subtypes of myasthenia gravis, juvenile, geriatric patient, ocular, and anti-muscle specific kinase antibody, we have to discuss in multidisciplinary meeting and to make a common decision about the role or not of surgery. So it is nowadays also we should have more randomized controlled trials that are required to confirm the benefit of thymectomy in this disease. And thank you for your attention.
Thank you very much, Dr. Al-Hamoumi. I would like to thank Dr. Al-Hamoumi for his comprehensive lecture. Actually, thymic surgery has a lot of controversies, and I expect that we will find some questions about more than one point regarding thymic surgery. Now, we would like to move to the next lecture by Dr. Belhassan about giant thymic tumors, surgical strategies. May I ask Dr. Belhassan to present his lecture, please?
شكرا الجزيل لكل هذه المبادرة مع الإخوة اللي كانوا من وراء creation for this group of Arab thoracic surgery. شكرا للدكتور عمرو إبراهيم، شكرا للدكتور عمرو عبد اللطيف، وأشكر أيضا الدكتور همون ياسين على هذه المحاضرة القيمة. Good afternoon, dear colleague. Let me present myself. I am Belhassan Smati. Professor of Thoracic Surgery, President of Tunisian Thoracic Surgery Association. In this occasion, I would like to invite all my colleagues of First National Congress that will happen in the capital of Tunis, which include our sensibilization exposition for promoting lung cancer screening. أفتح القوس بالعربية. احنا إن شاء الله يكون الكونغرس في 4 نوفمبر، وبعد 4 نوفمبر حيكون هناك تظاهرة في شارع حبيب بورقيبة، وهذه التظاهرة اللي مش تلمس المواطنين وأصحاب القرار وأصحاب الإعلام لتشهير باللنج كانسر اللي هو متفشي، واللي للأسف الشديد الديكوفيرت نتاعو هي جاية في المراحل الأخيرة، ونحاولوا إن شاء الله بالتقصي المبكر باش نحسنوا الوضع في تونس إن شاء الله. كل الأخوة مدعوين إن شاء الله لهذه التظاهرة.
شكرا.
So let's start with giant thymic tumor surgical strategies. Begin with the mediastinum is a complex anatomic compartment, and the tumor are qualified as orphan tumor. Half of this tumor located in the anterior mediastinum, and the pathology is varied by remains dominated by tumor pathology. Classification of thymic tumor has an impact for therapeutic decision. What is the aim of our topic? First, how to approach thymic masses. Second, diagnostic techniques of the thymic tumor. And finally, the therapeutic strategy for largest tumor. Thymic tumor, why is this difficult? The incidence of thymic tumor is low. Many years are needed to develop adequate clinical experience, includes a wide variety of lesion, and the clinical presumptive diagnosis is a matter of pattern recognition. The monoblock resection requires skills and experience, and the thoracoscopy with its advantage should be started whenever possible. This procedure requires experience. How to approach thymic tumor, especially when it's a giant one. Clinic data is very important, should always be available, age, gender, and radiographic characteristics. We often need duration of symptoms, and sometimes we need characteristic presentation and laboratory findings. Symptoms and associated diseases. For benign, the slow-growing neoplasm are often asymptomatic, but malignant lesions are frequently symptomatic with local signs and symptoms like cough, chest pain, vein cave syndrome, pleuropericardial effusion. Systemic signs, symptoms, weight loss, and night sweats, and body symptoms. Out of evident cases that the decision relies for non-invasive tools, CT scan, CT PET, and MRI. We have to aid by mini-invasive pathologic staging technique, CT-guided punction, or surgical techniques like mediastinoscopy, mediastinotomy, and video thoracoscopy. Finally, approach to thymic tumor. Confirmation of diagnosis requires tissue, but approach may vary from no biopsy for cysts or germinal tumor with positive alpha-fetoprotein or beta-HCG, core biopsy, resection, and surgical biopsy by video thoracoscopy. This procedure has the advantage to access to all mediastinal spaces and useful in cases of associated pleural effusion. When we need for histologic confirmation, in most cases, CT findings are sufficient for the diagnosis for teratoma, germinal certioma, or thymoma. Histologic is needed in cases of equivocal CT findings or suspected lymphoma or irresectable of advanced thymic tumor, induction chemotherapy, or exclusive chemotherapy radiotherapy. For the thymoma, occurs for men and women more than 40 years, 30 and 40 years. Myasthenia gravis may be associated with thymoma. There is 5 subtypes of thymoma: tumor carcinoma and neuroendocrine thymic tumor. This entity characterized by the slow onset of symptoms, exceptional for thymic carcinoma, neuroendocrine thymic tumor, only 30 asymptomatic. In conclusion, tumoma is evocated and the signs suggested for diagnostic in the CT scan. Here we show a huge tumoma, and the surgeon in some cases, when he look at this picture, ask if resection is possible or not. Here, for example, we have circumference of ascending aorta and vena cava. The diagnosis, the possibility of resection may be difficult. Fundamental surgical treatment is the radical resection tumor and involved organ. How to approach? We approach this first by median sternotomy. This is the royal surgical approach. This approach requires sternum opening, exploration of the mediastinal, anterior mediastinal, and permitted to combine resection and hypothetic reconstruction. These approaches may be insufficient, especially when the tumor invades the ileum or more than one lobe. In these cases, we can extend median sternotomy in the intercostal space, the 4 or the 5, the 3rd, 3rd or the 5, to do in mid-clamshell procedure. Second, the anterolateral thoracotomy. This approaches especially for lateralized tumor and lung invasion. Mini-invasive surgery for advanced tumor is represented by the video thoracoscopic surgery. The advantage for this procedure are no longer to be demonstrated, but surgical manipulation is difficult because the mediastinum is a limited space. Some advanced solution for this inconvenience. First, an ultra-sternal technique turned the subxiphoid approach to sternal lifting technique by use of Laparo lift system. 3, the sternum lifting using retractor and costal hooks. Here I use the video thoracoscopy with lateral thoracotomy for lung or pericardium invasion. Yano uses video thoracoscopy tumectomy via subxiphoid approach technique, and he can resect brachiocephalic vena with these roots. Okuda uses VTS tumectomy via subxiphoid approach using CO2 insufflation. The feasibility of this technique can be unclear in some cases because the huge and the invaded organ. But in my sense, I believe that combined classic procedure with video-assisted thoracoscopy surgery may reduce the extent of the incision. What about robotic surgery? This fashionable procedure. The future is promoted because the Da Vinci surgical system is superior, accuracy, superior visualization, enhances dexterity, and greater precision. In the future, we can see the real place of this procedure. Now we talk about advanced staging tumor, most large tumor fight in stage 3 or stage 2. The pre-treatment imaging findings shows large size and possible invasion of nerve organ and structure. Why? In some cases, the histologic diagnosis is important because we can separate between tumor or other entity that requires pre-treatment, neoadjuvant treatment, And in huge tumor, sub-entity of tumor is important because in some reports, type E and B can treat it as benign tumor regardless of the tumor size, and the others can require chemotherapy before surgery. Anesthesia, important time for surgery of the tumor. Multiple venous access is very important especially in the lower limb, because the vena, brachiocephalic vena, can be injured or can be clamped in the procedure. The double laminar tube, especially when we think that the videothoracoscopy must be used on first or orbital intervention. The anesthetic precaution for subclinical myasthenia gravis and for extended resection to the heart or supra-aortic vessels, cardiopulmonary bypass can be used, and the pre-therapeutic plane. What's about when phrenic nerve is invaded and the resection must be done? Only for curability. And we take in mind that in myasthenia patient or extensive comorbidity, the phrenic nerve resection can induce a pulmonary dysfunction. In these cases, if we can avoid the resection, is good for the patient. And some author report that sparing phrenic nerve achieved good long-term and disease-free survival in high-risk patients. Other is the contrary, reported higher risk of recurrence despite performance radiotherapy. If phrenic nerve is truly necessary, resection is truly necessary, the diaphragm application is recommended. It can prevent pulmonary dysfunction. What about the invaded of superior vein cava? Superior vein cava, when invaded, we must resect it. And the reconstruction can be done with direct suturing of the defect if is not attended, or anastomosis. The anastomosis can be done between superior vein cava, brachiocephalic vein, right atrial appendage, right left brachiocephalic vein. If double brachiocephalic vein resected, we start with the right atrial appendage and left brachiocephalic vena. The vessel replacement is no problem. There is a variety of choice for vessel replacement, and usually PTF Gore-Tex synthetic prosthesis is the material used in this case. The aortic arc is rare entity in the invasion of thymic tumor. We we can combine it, resection and reconstruction of aortic arc. Chantani reported a combined arc resection using total rotoring of supra-aortic vessels. We will describe this is tumor invading the termination of horizontal aorta. The first step is to clamp, of course, by cardiopulmonary bypass. We clamp the ascending aorta and we perform the first anastomosis between the ascending aorta and the prosthesis. The second step is to clamping the ascending aorta and we perform the anastomosis with the supra-aortic vessels. And the latest step is to remove in monoblock the tumor with the aortic walls and perform the continuity with the prosthesis between ascending aorta and descending aorta. This is just in comparison between the mini-invasive surgery and open thoracotomy in a large study. And we remark here that the size is not very, very important for decision. 4 centimeters, and we exceed to 15 centimeters here. And here, 6 centimeters, we exceed to 28 centimeters. In this conclusion of this author, the use of mini-invasive thoracoscopy for resection of thymoma is increasing substantially over time, and Many invasive thoracoscopy can achieve similar rates of R0 resection of tumor as open thoracotomy. We have to pass it for another type of tumor in the tumoma. The germ cell tumor is rare, 10 to 15%, and we identify seminoma and non-seminomatous tumor. Seminoma is sensitive for radiation and chemotherapy. Non-seminomatous germ cell tumor include yolk sac tumor, embryonal carcinoma, choriocarcinoma, immature teratoma, and mixed tumor. The treatment of primary mediastinal germinal cell tumor with cisplatin-based chemotherapy followed by surgical resection of residual disease is currently one of the most successful approaches of multidimensional therapy. In this paper, the rate of survival at 5 years for seminoma is 87%, and non-seminomatous tumor for the 3 years is 47%, and for 5 years, 25%. This results encouraged to start with this strategy therapeutic. What is the type of surgery? The type of surgery conditioned by the study of tumor marker. The serum tumor marker status is negative, is a good time to operate. In condition, the resecability of tumor in situ is possible. The tumor lymphoma is a rare pathology, often discovered with impressive volume in younger patients, asymptomatic. Myasthenia gravis or other autoimmune immune disease can be present, and in CT scan we have a large fatty density lesion, and this lesion approves the different organ in the mediastinum. Surgery in this case must be done with median sternotomy, because we must be careful not to open the tumor. If the tumor is open, we can forget a parcel of tumor, and disease must be the origin of recurrence. Thymic cystis, rare cause of mediastinal mass. In the most cases, it occurs with large cystis, may present with cough, dyspnea, and chest pain. Thymic cystis can have congenital origin. In this case, it present in scanner like unilocular, thin, and translucent wall. If it has acquired origin, it's multilocular thymic cystis and thick walls. The surgical approach actually proposed in thoracoscopic surgery, rare open thoracotomy. The amount of serous fluid can be aspirated to facilitate the dissection. Other cases, pharyngioma. This is relatively uncommon lesion of the lymphatic channels. This tumor can arise in virtually any part of the body. The mediastinum is rare location. This, in most cases, asymptomatic, and the CT suggested diagnostic showing a large cystis in the travel inside. How to remove this? It's the remove must be done without opening the wall. Then sternotomy, I think, is obligatory, and the dissection may careful, because opening the wall of the cyst, we lose the form of the cyst, and we can't remove the cyst entirely. The cyst can be the origin for recurrence. We pass now for teratoma. The incidence of teratoma 5 to 10%. There is mature and immature teratoma. mature teratoma can be cured with complete surgical resection. The choice between open thoracotomy and video thoracoscopy depended large size and or density of attached to the surrounding tissue. The residual parts should be destroyed by chemical agents or physical damage. In some cases, we can't dissect entire of the capsule of the teratoma, and in noble organ, we have to get some part in, and we will destroy it for avoid the recurrence. This is little experience in my private sector since 2011. And here I operated 11 patients, and in whom there is 4 invasive tumoma, started with new adjuvant chemotherapy, and like with the myasthenia, we try every time the video thoracoscopy. I explain 2 cases of huge lesion in thymic teratoma, 2 female with 28 years. The symptomatic was dyspnea. Both cases, the CT scan suggests cervical and mediastinal teratoma. The procedure proposed to video thoracoscopic surgery. In the first case, left lateral thoracotomy is done, and the second case is video thoracoscopy associated with manubrio. In fact, right VATS started and shows that dissection of right side of the masses. Then we do a manubriotomy. The mass extended on the neck and was continued with the Thymus gland. We successfully dissected it from the neck and the anterior mediastinum. It was dissected of pericardium and mediastinum together with both thymic lobe. In this case, we aspired 1.3 liter serous fluid were drained from the mass to facilitate the dissection from vein cava and the extraction of the right side. We show together the video of this second case. Excuse me, we can't open this. In conclusion, incidence of thymic tumor is low. Clinical data and preoperative investigation guide diagnosis. The interest of the preoperative histological diagnosis is essentially discussed if the resectability is doubtful. Thoracoscopy is gaining more and more space in tumor resection with the same oncologic results. For gene tumor is still a subject of discussion. Thank you, all my colleagues.
Thank you very much, Dr. Belhassan, for your informative lecture. And now we'll open the discussion and the questions. I think we have one question, Belhassan, from Dr. Hamoumi. What is the impact of corticosteroid on surgery of thymoma? And do you enlarge the margins according to pathology? Okay, so Dr. Rashid is asking, is there a difference between Oserman classification and Oserman score? I think this is the first part of the question. Would you please handle this part first?
Yes, of course. There is a difference between the Oserman classification system and the scoring of people. When we receive people for surgical indication, thymectomy, there are stable people, stable medical condition, and this Oserman classification is already done by the colleagues of neurology. So the most used one is the Oserman system that I made in the diapositive. In the scoring of people, of patients with myasthenia gravis is done by our colleagues. There is a difference, of course.
So regarding Oserman classification, I have a question here, please, regarding preoperative plasmapheresis. Do you do plasmapheresis for all patients routinely before thymectomy, or the selection criteria for those patients, some you do plasmapheresis, some you don't do preoperatively. And based on what classification you do that?
We use the Osserman classification, is the most used by our colleagues in neurology, and the indication of plasmapheresis or intravenous immunoglobulin is done by the same doctor neurologist. So when we receive people, they are in stable condition, and we never undergo surgery in unstable people or in intensive care unit. We wait until the condition is optimal and we perform surgery. So plasmapheresis and immunoglobulin can be required before surgery, and it is indicated when people are in a refractory stage or with some difficult symptoms. So we can use this technique, this immunotherapy, to reduce the clinical symptoms and to give more chance for surgeons.
Okay, and in the same way, I think you use minimally invasive surgery. And you mentioned that you use the left-sided approach, right?
Yes.
So there's a common question between surgeons. Do you prefer to insert the Mahawker for plasmapheresis on right internal jugular or left internal jugular? Sometimes people who do that right side, from the right side, don't prefer to insert the left-sided internal jugular, not to see the Mahawker inside the left brachiocephalic vein. During the dissection of the thymus from the left brachiocephalic vein, there is a possibility of injury of the left brachiocephalic vein by the hard Mahawker inside it. Okay, you get my point?
No, not yet.
So, what do you prefer to? Where do you prefer to insert the Mahawker for plasmapheresis? On the right side or left side?
It is done, as I said, by the neurologist colleagues, and it is done generally in the right side, and it is not a big question for us. The problem with the side chosen for thoracoscopic thymectomy is the exposure, the perioperative exposure, and we don't care about the use of perioperative plasmapheresis. The most important is the exposure, and principally the aortopulmonary window that we try to remove all the fatty tissue inside.
Okay, do you get the right-sided cardiophrenic fat from the left side?
No, it is difficult. Really, it is difficult. We use some specific optic with a 30-degree or a lateral view. It is possible, but really, it is more difficult by the left side. We try to remove all what we have in our view, in direct view, and we go to the neck area to remove the fatty tissue, some perithyroid fat tissue, and it's all. I'm sure that complete thymectomy is a very difficult purpose, and we try our maximum, but it cannot be 100%, of course.
Yes, so you agree with most of the surgeons that it is enough to remove the thymus gland from right phrenic nerve to left phrenic nerve, along with thymic horns and all visible mediastinal fat to the surgeon.
Yes,
right?
obviously, yeah.
Okay, and what do you think about the cervical fat? I think we can't remove every fat globule, especially it would be around the great vessels like innominate artery and so on.
Yeah, if you observe good the video, there is a part of fat tissue on the pericave area, and we didn't touch because of the high risk of vessels injury. So we try to remove the max of this tissue, but not to expose people to huge complications, especially when you use minimal invasive surgery to do conversion. It will be a consuming time step and a high life-threatening complications.
Thank you. So
I can ask you, what do you do in Egypt? Is it the right or the left side?
Yes, actually we do the right side. It is wider. Yes, we start from the right side, starting from the right phrenic nerve, then going to the supra sternal notch to the neck to get the horns, then to the left side till seeing the left phrenic nerve. And after that, we remove all mediastinal fat. So we remove from right phrenic nerve to left phrenic nerve, thymic horns, and all mediastinal fat. And the same, we can see the left cardiophrenic area from the right side. Sometimes we creep forward behind some mediastinal fat to the left, the early part of the left cardiophrenic hernia, but actually we can't get the whole fat in the pleura, left pleura.
Do you systematically open the pleural cavity, bilateral pleural cavities?
No, actually we open from the start the right side as we go from the right side, and opening the left pleura is not on purpose, just accidentally. We can just on the left side dissect the left thymic lobe bluntly till seeing the left phrenic nerve, and then we can stop. If we can't see it, we have to dissect to the left pleura till seeing the left phrenic nerve to be sure that we have removed everything to the left phrenic nerve. So we open the left pleura accidentally. Sometimes we open it, sometimes we don't open it.
Okay.
So let's see the second part of the question of Dr. Rashid to Dr. Al-Hammoumi. Which classification do you use? Osserman classification or Myasthenia Gravis Foundation of America?
Practically, we use the MGFA, the Myasthenia Gravis Foundation of America. It is more easy, and it is teach to young medical students. It is really practical.
Okay. Now let's shift to Dr. Belhassan. There is a question to Dr. Belhassan from your colleague, Dr. Al-Hammoumi. What is the impact of corticosteroid on surgery? I think this is the first part of question, right? Dr. Belhassan, please. Yes. What is the impact of corticosteroid on surgery, of thymoma surgery? Is there an impact of corticosteroid if the patient receives corticosteroid? Is there an impact on surgery of thymoma? This is a question to you from Dr. Al-Hammoumi. Do you change the protocol of your surgery, or there is an impact of that corticosteroid on your surgery?
For myasthenia gravis and thymoma, we choose the minimally invasive procedure. In the table, there is huge thymoma. I resect with cervicectomy and cervicomandibulotomy in 3 cases. I avoid sternotomy for myasthenia gravis associated with thymoma because it's possible to resect it with the minimal invasive procedure. I can do it.
Okay. So if the patient is receiving corticosteroid, you prefer the minimally invasive approach to enhance the healing, right?
I have one patient. When I see her in the first time with 6 centimeter size of the tumor and has unstable myasthenia gravis. The preparation with steroid reduces the size of the tumor 5 centimeters. And in this case, we do it via videothoracoscopy, pure videothoracoscopy through 2 hours.
Okay. And there is another question for Dr. Al-Hammoumi to you, Dr. Belhassan. If there is a different pathology, do you enlarge the margin of resection? Is there a difference in the margin of resection if the patient has thymoma or if the patient has, for example, thymic carcinoma?
We do thymomectomy in all cases, and we sure to have the limited non-pathologic.
Okay. Is there a difference in the safety margin between resection of thymoma and the resection of thymic carcinoma?
The same.
The same.
The same, because in the most cases there is a thymoma, so size can be large, and in prima bor, when there is resecability possible, we resect and keep it in mind to be in the margin, safe margin, in both thymoma or thymic carcinoma.
Great, great. So I have a question to you, Dr. Belhassan, please.
Mhm.
How big do you trust the radiological reports? What I mean, sometimes we see reports for MRI saying there is no line of cleavage between the thymoma and the pericardium, or between the thymoma and the innominate vein, and we go inside and we find a good line of cleavage between the thymoma and the pericardium, or whatever. So based on that, do you put a thoracoscope first in every case of apparently resectable thymoma? Or if there is a report saying that there is no line of cleavage between the thymoma and the underlying structure, you go directly to open sternotomy?
When there is a depth for clean limited of thymoma with pericardial on vessel, I start with open thoracotomy. Open thoracoscopy can help to not extend the procedure.
Okay,
But,
please.
When there is depth of invading structure, vessels, I open in the first intention.
Okay, so have you ever seen a tumor that wouldn't invading the pericardium or whatever, and after opening the sternotomy, you found that it is not invading, and you said to yourself, it would be better to start with VATS instead of opening the patient directly?
Is the contrary.
لحظات الندم يعني.
Because where there is depth of invading is invading.
Okay.
But I have a principle that all my procedure, I start with thoracoscopy.
Okay, so you start with thoracoscopy first.
Yes.
In all cases.
And when there is conversion to open, I open.
Okay, so we can say to our colleagues that if there is doubt if it is invading or not invading, we can put a scope first. If it is not invading, we can complete by thoracoscopy. If it is invading, we can convert to open, right?
Yes.
Yes, great. Okay, so now we'll get back to Dr. Al-Hamoumi and the question of Dr. Hassan Kabiri. If there is a percentage of post-operative myasthenic crisis in case of incomplete resection of the thymus in non-thymomatous myasthenia gravis?
Yes, thank you, Professor Hassan Kabiri. It is my chief, and he is my chief and study. About this question, people with positive anti-acetylcholine antibodies after surgery, after a successful thymectomy, we will get a reduction of the rates of these antibodies in the blood. But if the patient is seronegative, we have no way to control the success of thymectomy. So after a thymectomy, if the patient decrease the level of antibodies, we will not have myasthenic crisis. But if the patient is seronegative profile, we cannot predict the myasthenic crisis in the post-operative stage. So some people will develop myasthenic crisis and others no. It is depending of the medical associated therapy. It is depending of the complicated physiopathology of the disease, and we have no way to predict if the patient will develop this crisis.
Okay, so there is no relation between percentage of occurrence of post-operative myasthenic crisis and the amount of thymic tissue left from surgery, or we can't predict that.
Yes, we can't predict that. And as I said, complete thymectomy, 100% complete thymectomy is impossible, and we cannot relate the remove the gland to the postoperative results.
Okay, I think the thymic gland itself, we can see after getting the specimen out that we can see the thymic gland itself, but what we can't say is that it is 100%. It is not 100% resection the perithymic fat. We can't remove all perithymic fat. You agree with me?
I don't agree because it is not the purpose is not fat. The purpose is the thymic ectopic tissue, and it is in this fat. So the thymic gland is not just this gland that we see. It is all the thymic tissue.
Yes. Okay. On the same page regarding reoperation of the thymus gland. Okay. Do you see a lot of cases of residual thymic tissue with persistent symptoms after many years of thymectomy?
It is a real problem. It is a real problem in our practice that the communication between multidisciplinary colleagues is not very good. Really, when we operate the patient, we will do the following up for some weeks. And after we lost the patient, so that it is a good occasion to propose to our colleagues to continue the common following up of people. So I have some people with some patient with no remission, no success of thymectomy, and they get more therapies. Immunotherapy particularly, and after we lose the achievement of following up.
Okay, so how often
can you please ask Dr. Kabiri if I answer his question completely?
Okay, Dr. Hassan Kabiri, please would you show us if Dr. Hamoumi have completely answered your question, please? You can say just
yes, thank you.
Submit.
Yes, thank you. Yes, thank you, and thank you, Dr. Amr, for your communication.
Okay, thank you, Dr. Hassan.
Thank you.
So getting back to Dr. Belhassan. Okay, I have a question, please. It's been great your lecture actually to see how we can resect the superior vena cava, aorta, and any invaded part by the thymoma. So can we say that no thymoma is resectable? Yeah. Can we say that every thymoma is resectable? Or there is a rule for biopsy and radiotherapy or chemotherapy, or what I mean, adjuvant therapy, then we can go for surgery?
The huge thymoma, when entire the vessel, we must start by CT guided function to determine the type or subtype of the tumor. And for the huge, when resectable is not guaranteed, I would like to start with chemotherapy before. It can reduce the risk of thoracotomy without resection.
Okay, so if it appears to be resectable, even if it is invading important structure, you go for surgery with complete resection and reconstruction, right?
Yes.
But if it
appears, not, I have not for aorta, no, but with vena cava, with subclavian vessels, with pericardium, I have to resect it on monoblock. In one cases, I operated tumoma, carcinoma tumoma after chemotherapy, and in the ascending aorta, there is difficult to clean the wall. I don't perform the resection of the aorta because the condition is not good for that surgery, and the patient survive 5 years with this procedure with adjuvant therapy, chemotherapy, and radiotherapy.
How about your experience with the left brachiocephalic vein? We see, I think, some controversy about the left brachiocephalic vein invasions. Some people saying that we can just resect the left brachiocephalic vein and we can sacrifice the left brachiocephalic vein. Some saying that we need to make a graft. What do you think? Can we just sacrifice the left brachiocephalic vein if it is invaded?
when the wall is invaded, we must resect it. In the vein cava, we can, if the extended less than 2 centimeters, we can do direct suture. But if the extended of the invaded wall is more than that, we must perform resection of all and direct suture or interposition of PTF cortex.
So invasion of left brachiocephalic vein, we can just do sacrificing the left brachiocephalic vein without reconstruction, right?
Yes, yes.
Okay.
With the brachiocephalic vein, left brachiocephalic vein, we sacrifice without reconstruction.
Okay. Okay. Do you do routine diaphragmatic plication if there is phrenic invasion with resection of the left phrenic or right phrenic nerve? Do you do plication?
No. I sacrifice phrenic vein in 2 or 3 cases, but I don't do applicator because there is no comorbidity, no myasthenia gravis. Donc I am sacrifice the vein and the nerve without the diaphragm applicator.
Okay. So now getting back to Dr. Al-Hamoumi again regarding ocular myasthenia.
Please, I have a question to Dr. Smati. Do you?
Okay, please.
Yes.
Dr. Samati, there's a question from Dr. Al-Hamoumi. Okay, please.
About the resection.
Welcome, Dr. Hamoumi.
Thank you. About the resection of the superior vena cava, do you use the cardiac bypass or just the classical general anesthesia? And how much do you clamp the superior vena cava? Is it more than 30 minutes? Do you need to this cardiac bypass or just direct clamping?
No, we don't need for vena cava cardiopulmonary bypass, but we can clamp it more than 3 minutes. There is no problem. Before clamping, we must put heparin, and we resect the whole invaded by the tumor, and we do direct suture or prosthesis. There is no problem for the timing for vena cava.
Okay, thank you. Yes, Dr. Amr?
Yes. About ocular myasthenia, what is your feedback regarding patients who had ocular myasthenia and had been operated for myasthenia gravis by thymectomy?
Ocular myasthenia in our practice is not very frequent. Over the last decade, we have seen about 10 or 15 people, and we can note that there is a direct improvement in the clinical outcome. This we note this in the direct following up during the postoperative stage.
Okay.
So in our teamwork, we indicate thymectomy for ocular myasthenia gravis, even with the negative antibodies.
So you do thymectomy for ocular myasthenia?
Yes.
Okay, and you had good positive results for that?
Yes.
At all ages, what about young patients, like patients in 12 years, 13 years? I think we see some resistance in improvement from those patients' special experience.
In fact, our experience is really limited in the child population because our hospital didn't receive younger people. So we don't do pediatric thoracic surgery. So I can't respond to this question.
Okay, thank you very much. Okay, so there is a question from Dr. Ala, I think, to Dr. Belhassan, about the role of resection of pleural mets of thymectomy, mediastinectomy for chemo-resistant tumor. I think he's speaking about thymoma with pleural metastasis. Dr. Belhassan, what about your experience regarding thymoma with pleural metastasis?
Only one experience thymoma with pleural metastatic. This 15 years ago in an orthopedic surgeon.
Okay.
I operate it the first for pleural effusion and mediastinal masses by thoracoscopy, and we do the biopsy, shift the fluid, and after that we treated it with chemotherapy. Chemotherapy reduced significantly the size of the tumor. Then we operate it, and him and via sternotomy we do tumomectomy and all the surrounding tissue. And for the pleural metastasis, there is pleural metastasis, we treated him with intrapleural cisplatin.
Okay.
He survived about 6-7 years, and I don't know he's alive or not, but 6-7 years he's in life after multimodality therapy.
Okay.
Thymoma with metastatic pleura in the left side.
Okay, may I ask you or Dr. El Hamoumi if you have any current experience or plans for future experience regarding intraoperative hyperthermic pleural chemotherapy for thymic metastasis, pleural thymic metastasis? Do you have any current experience or planning for future plans for adopting this technique at your operation if you have a patient with thymoma and pleural metastasis?
Yes, Dr. Al-Hassan.
I don't know.
Really, we don't have an experience with intrapleural chemotherapy, and it is not used in surgical departments. It is used in oncological departments, so we have no experience about.
Okay, just we can share here a limited experience for us regarding that. Some cases of thymoma with pleural metastasis. Now we have done just 2 cases. Recently, we started that program just about 6 months back, and we have done 2 cases. We can use the cardiopulmonary bypass to circulate intrapleural hyperthermic intraoperative chemotherapy. So we start the procedure. Mostly, it is usually invading thymoma. So we start the procedure by median sternotomy, and then put the patient on the decubitus position. Mostly, it is invading one of the lobes, and we have done 2 cases: resection of thymoma with left upper lobectomy, then pleurectomy, and the intraoperative hyperthermic chemotherapy, using the cardiopulmonary bypass to circulate the intrapleural chemotherapy. And actually, they are going well till now, okay? So I think we can share this experience with our colleagues. So you can use, I know that there is a specific machine for intraoperative hyperthermic chemotherapy, but instead of that, most of us at cardiothoracic surgery department, so we have all of us, most of us have cardiopulmonary bypass at their department, so we can use it to circulate the intrapleural chemotherapy. So now,
what about the results? The results in this?
Yes, till now we have done just 2 cases within the last 6 months. Till now they are going well. Follow up PET scan negative, and they are okay.
Okay, very good.
Okay, so now actually it's been very interesting discussion, and we have just 4 minutes. So for all colleagues in the discussion, if there is any further question, please submit it on the chat. دكتور رشيد ممكن يتفضل بالسؤال بتاعه؟
شكرا دكتور عامر، شكرا
الله يعطيك
دكتور
العافية فندم.
عمرو، فخور جدا بالمشاركة في هذه المحاضرة الطيبة والقيمة. I insist for one question because I practice my surgery in a low-level hospital. So I really want to say on severe form of myasthenia gravis, what's the minimal conditions required to perform surgery so that Professor Hamoumi call a stable patient? Which conditions is required to define patients as a stable in terms of drugs quantity and number of molecules and stage of disease?
Thank you, Dr. Rashid. this is a real problem to obtain the optimal state of a patient with severe myasthenia gravis. So we can speak about stability of the disease when we have no respiratory symptoms, when the patient didn't need invasive ventilation, when the doses of immunotherapy are not very high, and where we have no major side effects. All of these conditions, all of these situations make our patient is stable. But we want more. We want to reduce therapy. We want to get more independent quality of life. So we propose thymectomy in these situations to improve the outcome.
In my experience, I operated a patient in under respiratory, and the preparation that all immunotherapy, electrophoresis, the protein, but we can't dissolve the respiration. There is I operated him, and the second day we can with tracheotomy, tracheotomy, and we believe that the second day without the respirator.
Okay.
Yes. I don't understand what's happened, but the patient is really improved after surgery.
Very nice.
So the patient had good response to surgery.
Yes, good
Fast response
after all preparation with the reanimator, but the surgery is reserved this problem.
Great.
In 24 hours.
Great.
Yes, I think that when we don't have other solution apart from surgery, we can propose this for the family of the patient, especially when he is under mechanical ventilation. It is possible, but I can't make sure the results of surgery. It is a good case to report. It is a very good one, but we have some particular cases with negative results.
If I have, I can ask a last question about lymphadenectomy in thymic carcinoma. Is reported as a prognostic factor by rhythmic group. What do you think, Professor Hamoumi, Professor Smati?
Monsieur Smati?
Thymic carcinoma with adenopathy. We must search and reject all the adenopathy in any tumor. But what's the prognosis of positive lymphadenectomy? I don't know. Is there is impact in the prognostic or not?
It's a prognostic factor.
Yes. Of course, when we have a pathologic results in favor of thymic carcinoma, we are invited to make a lymph node resection, perithymic lymph node resection. It is a prognostic factor. So even with the new classification, the TNM of thymic epithelial tumors, we speak about the N. So we have this question of lymph node removal. It is mandatory in my sense, and with a real prognostic impact.
Now, if we agree of the necessity of lymphadenectomy, it is a question about the way to practice the surgery. It's that is always acceptable as a technique to use in thymic carcinoma, because we can't practice lymphadenectomy all areas lymphadenectomy by VATS.
Why? By VATS we can
you understand me?
Exceed to the all station of adenopathy. There is no problem.
You should make a difference between the lymph removal. It is not like the lung cancer. It is just the anterior mediastinum. So we go ahead in the pericave, in the peri-innominate vein, and in the aortopulmonary window. Not elsewhere, I think.
Now, in the rhythmic group, they defined 3 zones of adenopathy. So some zones are very deep behind vena cava in the right side and in aortopulmonary window in left side.
It is feasible by video thoracoscopy, especially when you use the subxiphoid approach. We can approach the pulmonary artery window. We can approach the right side. So I speak that I say that it is possible. It is possible.
Okay. Thank you. Thank you all.
Thank you.
Thank you very much, Dr. Belhassan. Thank you, Dr. Al-Hamoumi. Actually, it is very interesting discussion. We don't want to end this discussion really, and it is our pleasure to meet today Dr. Al-Hamoumi and Dr. Belhassan and all Arab colleagues here. And now the speak for Dr. Amr Ibrahim. Thank you very much for organizing this discussion, and we hope to repeat this many times